All right, well, let's get started. My name is Carrie Billy. I'm the president and CEO of AIHEC, the American Indian Higher Education Consortium. And on behalf of the nation's 37 tribal colleges and universities, which are AIHEC, I want to thank you all for joining us. On behalf of AIHEC, the National Native Research Network, and the Indian Health Service, I welcome you to the first ever National Native Health Research Training Webinar Series. The theme for this series, which will extend over the next several months, is the National Tribal Health Research Agenda: Governance, Trust, and Culture. I always like to start whenever I'm speaking with a land acknowledgement, and usually I'm speaking to a group of people in a certain place, but we're all virtual all over the United States and even in Canada today. So I want to just acknowledge the first people of the land where I am, here in Northern Virginia near Washington, D.C. I am on the homelands of the Anacostans, Piscataway, and Algonquin people. And I hope that everything I say and do here today and everything we do collectively honors their sacrifice, their love, and their care for this land. I like to do that because it reminds me of our creation stories, and we are all people of this place, of this land, and that is particularly important to us. So I think that's important for us to keep in mind. And we also always like to start our meetings in a good way. And I want to, we want to do that again today by thanking Mr. Clayton Stewart for being here with us to give our opening blessing. Clayton Stewart is from the Wolf Clan of the Saddle Lake, Alberta, Canada, Treaty 6. He is a pipe keeper and a traditional healer. Since 2017, he has supported the spiritual, emotional, personal, and knowledge journeys of the students and health researchers at the Waakebiness, Bryce, Dalalana School of Public Health at the University of Toronto. So thank you, Mr. Stewart, for opening our webinar series in a good way.
Well, thank you, Miigwech. Again, I just want to say thank you for, I'm very happy to see all your wonderful faces. My name is Clayton, but everybody just calls me Clay. I am part of, I've introduced myself. My name is Clayton. My spirit name is Running Wolf. I belong to many societies. I belong to a Midewewin society. I am Potawatomi and Plains Cree. So, but I lived here in Toronto most of my life. So I've embraced the Potawatomi, and that's a part of the Confederacy of the Ojibwe Nation. And that's Darwin, Potawatomi, Ojibwe. And with that, I'm going to say this opening prayer I try to live by every day of my life. I'm going to say this in this language. I don't really speak my language that well, Cree and Ojibwe. I'll just say this, I know enough. If my elders are talking about me, come here, all of this. And I belong, again, I belong to many societies, but I've just considered myself a practitioner of my culture, of my faith, of my spiritual practices. Now, I'm a father of 3, grandfather of 1. I've been in Toronto most of my life, so I consider myself an urbanite, an urban Indian, we'll use that word. And I love my city, I love my community. But we've been working in the community for the last 15 years with healthcare, just working and doing what I can in my community. So with that, I just want to say welcome to everyone. And we're from all over the place here, many nations here. And it's so wonderful to be a part of this and to do this opening. It's challenging times. It's very challenging times. And we're all dealing with it. And my heart goes to you, to my Southern brothers and sisters down there in the United States. So many of you are sick and dying. And this is what we're here to talk about, is education. And I'll just quote one of my chiefs, And he belongs to the same society I belong to, and that's Murray St. Clair. And he says, education got us in this mess, and education is going to get us out of this mess we're in. So it's very important to understand that, and slowly educating myself, self-taught here. I've sat with my elders for many, many years, learning and trying to think Anishinaabe. What that means in my language, Anishinaabe, is human beings. We're the human beings before we're anything else. Our race, our gender, our class, our citizen, and all the tribes have a way of knowing this word. They have a different word, a way of saying it. But we always identify of this, the people, the human beings. So I approach the circle of life with that understanding, that deeper sense of that, of what it is to be a human being. Human, bone, flesh, and blood, liquids, minerals of the earth. That's where the human comes from. The being comes from our relationship to the sun, to the sky, to the universe. All things of the earth have being, but we're the human beings, and we humble ourselves. We appreciate this gift called life of being a human being, Anishinaabe. As a human being, I approach you, my sisters and brothers, today in a humble way to offer this prayer. This prayer says, Miigwech. I always like to acknowledge our first mother of all mothers, our mother, the earth. Again, we offer our tobacco, our sema to her. Again, we pray to her. We pray for her. We give thanks to our mother, the earth, for everything she provides for us, the people, the human beings. We give thanks to her. She's so beautiful. We give thanks to her for everything she provides for us. There's so much to say about you, my mother. But I'll say miigwech to you for all the medicines you provide for us to help us to heal our minds, to open our minds, to open our hearts, to make ourselves better. I say miigwech to you. I love you. I say miigwech. So our minds can be one with this. I say miigwech to you. I say miigwech to Father Sky, that spirit world. Again, I ask the spirits of our ancestors to be here with us in a good way, in a sacred way. Spirits of our ancestors to help us, to guide us physically, mentally, spiritually, emotionally, to help us to clear our minds again, to have a good mind today, have a good talk and share and listen to each other. With a good mind and a good heart, I give thanks to Father Sky, to our ancestors. I ask them to give us strength, to have pity on us in these challenging times. We come together as the people, the human beings. So our minds can be one with this. I say miigwech. I say miigwech to grandfather of all grandfathers, grandfather son, for shining, for giving the appearance of rising in that eastern doorway, for bringing warmth, a new day, a new beginning, for making things grow for us, the medicine to heal ourselves. I give thanks for this beautiful day, grandfather. You are so bright today. You bring warmth. You bring a new season called summer. We plant our seeds. We grow our crops, our medicines. We give thanks for this. I give thanks to Nukamis, grandmother of all grandmothers. I offer my sema in gratitude. Nukamis, grandmother of grandmothers, Grandma Moon, as I sleep, as my children sleep, as we sleep, as our loved ones sleep. You do this very, very special thing in many things, but we acknowledge this. I acknowledge this. You put the waters, the rivers, the lakes, the oceans into order for us, the people and our relatives. For water is life. We acknowledge this. So many of us have forgotten this. May we have this understanding in our minds and our hearts. We give thanks to you, Nukamis, for everything you do for us. I love you, Nukamis. I send my prayers, my heart to you. I pray to you, I pray for you in gratitude for all the medicine you provide for us as we sleep, as our children sleep. You do this for us. Miigwech, I thank you, Nukamis. So our minds can be one with this. I say miigwech to you, Creator. Stand here as just a man, I say, to have pity on me, that I am pitiful. I am nothing without you, for there is nothing beyond you, Creator. I say miigwech to you for this beautiful gift you have given us called life. We gather our minds today to talk about this. I say miigwech to you, Creator, again and again. I ask for your blessings in for all of us today, to help us in these challenging times, to have pity on us. We have forgotten. Some of us have forgotten. I forget so often that I am an Anishinaabe before I'm anything else, a human being. May I understand this deeper meaning of this gift you have given us all called life. I acknowledge this. We acknowledge this. I offer my same awe and gratitude, Creator. For there is nothing beyond you, Creator. I say miigwech to you. Miigwech, 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 all my relations. Miigwech, thank you. Thank you for allowing me to say this simple prayer that I try to live by every day of my life, and I fail miserably at it quite often. So, miigwech.
Thank you, Clayton. Thank you very much for your beautiful prayer and blessing, and for reminding us of our collective humanity, both with people, other people, which is so important at this time, but also with the physical world, with the sun, earth, wind, water, sky, such important words. And also, thank you for reminding us that the sun will come out again, because I think in times like this, it's easy for us to forget that. And most important, thank you for reminding us through your example of how to walk our lives in a good way. So thank you very much. We appreciate it. So I'll go back to the webinar series now, and this webinar series, like the annual conference that preceded it, grows out of our shared commitment and partnership between AIHEC, NRN, Indian Health Service, and others to strengthen American Indian and Alaska Native tribally directed research capacity through greater collaboration among Native researchers, other researchers, and tribal communities. Our vision is to develop the capacity of our Indian tribes, Alaska Native tribes, tribal colleges, and tribal communities to plan, manage, and use the outcomes of our own health research to guide changes in our health policy and practice, and to reduce health disparities within our own communities, to take ownership of our research so our tribes can truly exert their sovereignty. So thank you all for being part of this webinar series and this initiative. We appreciate it. And before we get started with our presentations, I wanted to cover a few housekeeping issues. First, a request. We have a pre-evaluation, which you can see the link to the evaluation, which is kind of long, or you can just go to www.nnhrti.org, and that will connect you to the pre-evaluation webinar. So we're trying to do a pre and post evaluation. So if you could do that, we would really appreciate it. Next, we have a few protocols. All participants are muted by our host, Maggie Grandin, but just in case, if you could, mute your devices in case something goes wrong, we would appreciate it. The webinar is being recorded, and it will be posted on the nnhrt.org website after it's edited, so very shortly after this presentation. And as I said, all participants are muted. We hope that we will have time for a few questions and answers after the speaker's remarks. But as you can see, if you could type those into the chat box or email them to Maggie Grandin, mgrandin@aihec.org, she will be moderating the Q&A after the speaker's talk. Also, if you have technical difficulties, if you could just send an email to Maggie, mgrandon@aihec.org, she can help you take care of those. Now, for our agenda, we're going to first hear from the Indian Health Service, Rear Admiral Weahkee. He's going to give some welcoming remarks, and then we have our keynote presentation with Dr. Suzanne Stewart, who's going to talk about Indigenous health, healing, and research, particularly in these challenging times with COVID-19, and talk about some strategies for moving forward. And then we have a special hour for students, American Indians and Alaska Natives who are interested in going into health research or who are just thinking about that. Dean Seneca is going to give a talk on what is public health for particularly for students. So if you're students or you have somebody who might be interested and they're not sure, send them an email really quick and make sure they jump on for our last hour for that. Okay, I'm going to stop sharing my screen now and introduce Dr. Weahkee. Dr. Weahkee is Zuni. Sorry, I can't believe I said that because I even had a joke that I was going to introduce Rear Admiral Michael Weahkee. He is not a doctor, but his wife is. He is, I can hear you all laughing about that, but anyway. I'm sorry about that, but Rear Admiral, we're so happy that you're here. He's an enrolled member of the Zuni tribe and director of the Indian Health Service. And I know you are extremely busy right now, so we really appreciate the time that you're taking to welcome all the people on this webinar and others who listen to it. And we're just looking forward to your remarks. Thank you.
Thank you, Miss Billy. Just doing a sound check. Can you hear me okay?
Yes, perfect.
Excellent. Well, and my wife will get a kick out of your opening statement. She teases me all the time about she being the doctor and I'm just a lowly admiral. So we'll laugh about that at home this afternoon. Good afternoon, everyone. I'm happy to join you all for this first of 6 planned webinars as part of the National Native Health Research Training Webinar Series. I'd like to thank the American Indian Higher Education Consortia and the Native Research Network for hosting this webinar and for the great work that you all do across Indian country. Your efforts to bring together this large dynamic group of tribal public health researchers and advocates will have long-term positive impacts on tribal health research and the communities that we serve. I see that there's an excellent agenda laid out for you all today, filled with knowledgeable speakers. I saw my friend Dean Seneca on the list, so glad to see his name in the mix. All of these who are experts on a range of health topics specific to American Indian and Alaska Native people. Over the next 2 hours, you'll be provided with a comprehensive overview of the latest research developments, opportunities, and findings to increase effective use of research that addresses the health needs of tribal communities across the country. The theme of this webinar series, Tribal Health Research Agenda, Governance, Trust, and Culture, is what we're here to all talk about. So I'd like to provide just some brief updates for you this afternoon about our work at the Indian Health Service as we progress into the recovery phase of our COVID-19 response efforts. Over the past several months, the Indian Health Service has worked closely with our tribal and urban Indian organization partners, as well as with state and local public health officials and with our federal agencies to coordinate a comprehensive public health response to this pandemic. Throughout our efforts, our #1 priority has been the safety of our Indian Health Service patients and our employees. We are committed to strengthening our partnerships and to working collectively to respond and recover from COVID-19 in Indian country. We recently announced $500 million in payments from the Provider Relief Fund to the IHS and tribal hospitals and clinics, as well as to our urban Indian health centers to support the tribal response to COVID-19. This distribution brings the total amount of new coronavirus-related resources into the Indian health system of care to $2.4 billion. And these resources will make a huge difference in expanding our available testing, supporting our public health surveillance, and providing healthcare services across our system of care. We're detecting COVID-19 through screening and state-of-the-art lab testing. Through White House-led testing initiatives, we've been able to distribute, or we're in the process of distributing, a total of 350 Abbott ID Now rapid point-of-care test analyzers, as well as hundreds of thousands of testing supplies for various different testing platforms. Earlier in May, we began distributing remdesivir to IHS and both federal and tribal hospitals. Based on the requests that we've received and current burden of patients with COVID-19 who are hospitalized in an ICU setting, remdesivir was shown in a clinical trial to shorten the time to recovery in some people. And HHS has provided the IHS with access to 8,000 vials of this new drug, and it's being supplied to patients at 15 of our IHS and tribal hospitals across the country. As we move towards the recovery phase of our COVID-19 response, we will continue to work with our stakeholders on a phased return to normal operations in all of our workplaces and to restarting the American economy. The IHS plan for returning to normal operations is based on the department's implementation guidance, which outlines a three-phased approach that places the health and safety of our employees and their families at the center of our decision-making. As we work on implementing the phased return to normal operations, timing will need to be continually assessed, and we'll keep everybody informed and updated as we progress. We continue to strongly encourage everyone to follow CDC guidelines and instructions from their local, state, and tribal governments to prevent the spread of COVID-19 and protect the health and safety of our communities. We know that these are trying times for everyone, but we're all in this together, and we will be stronger in the end. I want to thank you again for inviting me to speak with you today, and I hope that you have a great training experience. With that, back to you, Miss Billy.
Great, thank you very much, Rear Admiral. We appreciate your remarks, and especially your focus on transparency and getting out information, because that in times like this really is a way to reduce fear. And so we appreciate that, and all your proactive work and the additional funding that's going into helping care for American Indians and Alaska Natives throughout the country. So thanks very much for your hard work.
Thank you, Ms. Billy.
We appreciate it. Well, with that, we are going to turn to our keynote speaker today. I'm very excited to introduce Dr. Suzanne Stewart. Suzanne Stewart is a member of the Yellowknife Diné First Nation. She is a registered psychologist and director of the Waakebiness, and she can correct that if I have it wrong, but Waakebiness Bryce Institute for Indigenous Health at the Dalalana School of Public Health at the University of Toronto, where she is an associate professor in the Division of Social and Behavioral Health Sciences and the research chair in Aboriginal Health. Dr. Stewart is an international expert in Indigenous homelessness and mental health issues, and we are excited to hear Dr. Stewart's remarks today on Indigenous health and, most important, healing and research, particularly in light of the COVID-19 challenges that have been impacting our people for the past several months. So, Dr. Stewart, I'm going to hand it over to you now. Thank you for being with us.
Hi, thank you so much for having me. Can you hear me okay? Great, great. I'll get started. Thank you so much, Clay, for opening us up with spirit in a spiritual way. And thank you for everyone else for speaking and setting the tone, doing the territorial acknowledgement for where all of yous are. It's a great honor for me to be here today. I was really excited about coming to this conference in person and meeting everyone last year and then in the spring, but I'm equally excited about meeting here online, and I hope that we can all meet in person soon when this is all over. So before I get started with the presentation, I'd like to also just quickly acknowledge the territory that I'm on here in Ontario. I am from the Yellowknife Diné First Nation in the Northwest Territories, and I visit in a capacity where I live and work here in Anishinaabe and Haudenosaunee territory with people of many nations from these groups, and in particular right here in the area where I live, the Mississaugas of the New Credit and the Six Nations of the Grand River are our closest reserves. So I just acknowledge their leadership in Indigenous wellness and health here. So miigwech or masicho to them, so thank you. I also want to acknowledge our research team that's working on many different projects that we have. We have about 25 research projects in Indigenous health that we run through the Waakebiness Bryce Institute for Indigenous Health here at the University of Toronto. And the team that works on the project we're going to talk about today, which is around an Indigenous COVID response, our elder or traditional teacher, Clay, who did our opening today. We also have Christine Skura, who is a Métis nurse. That's her on the right. And Kira, who is one of our recent graduates in the Indigenous Masters of Public Health program that we run through the Institute, as well as Joshua Adams, who's a research assistant, and Cohen Pinko, who is an Indigenous Youth Community Research Assistant, and Kathy Fournier, who I didn't get a picture of Kathy in time, but Kathy is an Indigenous Special Projects Officer for Indigenous Research Policy and Ethics at U of T that works with me around changing some research policies at U of T. So this group of bright and industrious, hardworking people in Indigenous health has been working with me since the beginning of the pandemic to really address what some of the issues that have come up. Now, our team has worked very cohesively and in-depthly around Indigenous health issues to do with Indigenous food security, Indigenous mental health, Indigenous homelessness, Indigenous health and education, and cultural safety in healthcare, both in hospitals and in primary care settings. So when the pandemic hit our community in urban Toronto in early March, all of the people who worked in Indigenous health research sort of came together. So that's really me and about 5 other Indigenous academics across the greater Toronto urban area. And we came together and we began to articulate what some of the issues we were immediately facing, because we knew that many of our populations within the urban Indigenous populations had the potential and the reality to be profoundly impacted by COVID-19 and by a pandemic coming into the city. And just to give you a little bit of context, Toronto has one of the largest Indigenous populations in Canada. By various accounts, there are anywhere between 80 to 150,000 Indigenous people living in Toronto, depending on who's collecting the data or who you ask. We know that that Indigenous people have a higher burden of disease and mental and physical illnesses. So that right there begins to put people at a disadvantage when it comes to dealing with the pandemic. We know that Indigenous people are, hang on, sorry, I just have to change something on my screen here. There we go. Indigenous people are highly marginalized within health and social services in Canada in general, but in urban areas specifically. And from that perspective, we know that COVID-19 has a greater impact on our Indigenous population in ways such as the economic impact will be very deep for Indigenous people. Social isolation will be a greater issue because many Indigenous people in urban areas are already socially isolated. Self-isolation is an issue for people who have precarious housing or who aren't housed. Healthcare is already an issue because in Canada, the greatest barriers to health for Indigenous people are not biological or technical processes, but are in fact racism and access to healthcare rather than biological health itself. Water is an issue for many Indigenous people, especially off reserve, and travel is another issue because many of our communities outside of urban areas are isolated and hard to get to with healthcare workers already coming and dropping in a sort of helicopter model. And before the pandemic started, people were sort of wondering how that was going to work, especially if borders were going to be closed around reserves, how we were going to get healthcare workers to travel in and out of the community, or how people who needed intensive hospital care were going to be able to travel out of reserves and to urban areas where they could get that care. And then the other issue around COVID is the precarious employment that plagues Indigenous communities, who are already highly unemployed as a population, with unemployment for Indigenous youth, for example, from my research and the research of other Indigenous Canadian health researchers, showing that the unemployment rate for Indigenous people, depending on where they live, is anywhere from 50 to 90%. So the current issues for Indigenous people with COVID are really about understanding that, first of all, Indigenous people in Canada are more vulnerable to COVID-19 community spreading because of the issues that I just mentioned. Urban Indigenous people are being ignored by government and healthcare responses to COVID-19. Indigenous communities are not getting direct messages from the government about COVID-19. Misinformation is being circulated in Indigenous communities about the pandemic, about health and wellness, about how to stop spreading, about everything. There's a lot of misinformation in our communities right now. And Indigenous healers and elders are not being consulted by the government or biomedical systems when it comes to addressing Indigenous needs for COVID-19. And lastly, which is really the underpinning of what creates all the other problems from my perspective as a researcher, is that the government is continuing to impose colonial models of healthcare and public health on both Indian reserves and urban Indigenous settings when it comes to addressing the pandemic with our people. So that being said, that's sort of the background of what we're dealing with. I've teamed up with Dr. Janet Smiley at the Well Living House, which is another Indigenous Health Research Institute at the University of Toronto, which is situated at St. Michael's Hospital. And Well Living House and Waakebiness, Bryce have been working together on various specific initiatives around dealing with COVID-19 and the urban population, as well as addressing COVID-19 at the national surveillance level. So why do we need a specific Indigenous response? And a lot of other researchers and policymakers have been asking me this. So I've made it very clear. Despite efforts to enhance cultural competency and culturally based services for Indigenous people throughout the healthcare system, Indigenous people today continue to have very bad experiences in healthcare. That's to do with racism, discrimination, and lack of access. This is still happening on a daily basis. Secondly, this is actually really critical during the COVID-19 pandemic, because our people are extremely vulnerable to higher levels of community spreading and fatal outcomes because of the social determinants of health that have been created and enforced by Canada, by the cities, by the healthcare system, by the social service system. And further to this, none of the current COVID-19 assessment or treatment services that exist in Canada, from where I can find, have actually been adapted for Indigenous people with any of this critical context in mind. And there has been no cultural safety training for any of the pandemic response teams that have been put together by the hospitals. And there is also no pandemic assessment or treatment models that have been evaluated or developed from Indigenous research methods or Indigenous ways of knowing, and no way that has been written by any public health team about how to follow up with Indigenous people to find out what happened to them during the pandemic. There are a few challenges that we need to address in this, and that is that, of course, Indigenous services and interventions are difficult to ethically and accurately measure from Western paradigms. And currently in the Western healthcare system, there are no evidence-based Indigenous evaluation frameworks that are being widely used. Well Living House and Waakebiness Bryce Institute, so Dr. Smiley and myself have been working on developing these Indigenous evaluation frameworks, but they haven't been recognized by the biomedical healthcare system at this point. Another challenge is that traditional knowledge keepers, elders, and healers have, of course, been reluctant due to historical and ongoing colonization of health services and research, reluctant to engage with universities to evaluate their work. And healthcare systems for Indigenous people here in Canada focus exclusively on Western biomedical health services with really little or no emphasis on culturally safe or culturally based models. And what we see here in urban Toronto is really no exception to this. So what are we proposing to do from a research perspective with COVID-19 here? What we want to know is, how do urban Indigenous people access and use health services for COVID-19, and what culturally based health services and information are most effective at preventing and ending this pandemic in particular? So what we've really done to, first of all, develop and then to answer this question has been what we've always done in our research institute, and what I've been doing for the 20-some years that I've been working as a quote-unquote researcher, is to go right to our community partners and go right to our elders and say, this is happening right now, what can we do to help? And what our community partners have said is that we basically need to create interventions that the communities, the community partners, and the people who are already working with our people out there in the city can use to address actually what's happening on the ground right now. And that they'd like us to create and embed Indigenous evaluation frameworks within these emergency services that we're developing with them, and in consultation with other community partners across the city and across Canada, and to basically create a framework for pandemic response that can be implemented and evaluated using Indigenous knowledges as the framework for all of this. So in other words, really in broken down easy terms, it's about going to our elders, going to our healers, saying us in downtown Toronto, going back to our community partners who also work with the same elders and healers, and then translating those recommendations, suggestions, and knowledge into actually applied services and interventions. That for our community partners have really been about what AIM 2 says on here, and that's developing an Indigenous community assessment and treatment center for COVID. So basically developing our own center where Indigenous people, whether they're homeless people or whether they're privileged upper working class people like myself and my family, where Indigenous individuals who think they might have COVID or who want to get assessed, who want to get tested, can go and get culturally safe assessment, testing, and treatment. The other thing that our community wanted was, in order to address that paucity of accurate knowledge and information about COVID, is to create a database of Indigenous information on COVID-19 that would be taken both from traditional knowledges and biomedical information and system that would be delivered in a culturally safe and culturally based way. And that would be to stop community spreading, as well as to connect people virtually through the sharing of that information that is also informed by traditional knowledge keepers. So our sort of aims in this project are really to get information out there and to provide support, assessment, testing, and treatment that's culturally safe in order to actually prevent the death, the unnecessary deaths of our people who are who may not be going for assessment, treatment, or testing because they don't feel culturally safe to do so. So I talked a lot about how we had designed this project, sort of when I was sharing what the research question, quote unquote, and those are very Western terms. But really, this project is designed and driven by community interests and needs. Any projects that our team does is really driven by what our community partners need, and that really starts at the sort of pre-proposal stage. We have about, I would say, I haven't counted numbers yet, but we have over 25 Indigenous community partners that are both local, national, and international that we work with at our research institute. And they reach out to us when they need help with something or a crisis erupts, and they ask us to help them either do a research or evaluation or provide other services. A lot of the work that we do at the Institute may not actually be directly relevant to a particular research project, but is still filling a need that a community partner has in order to continue to stay in relationship and to demonstrate reciprocity. So for example, one of our community partners called me up at the beginning of a community partner on a different project to do with cultural safety and cancer screening, called me up and said, our elders have told us we need to give cedar to all of our clients, and this community partner is an inner city health organization that services the Indigenous homeless. Their elder had told them that they needed to give cedar packets to all of their clients on a weekly basis, and that they had run out of cedar. So we have members of our team picking cedar every week, making cedar bundles and delivering it to that organization on a weekly basis throughout the pandemic. And it's possible we may continue to do that throughout, a longer period of time. But that's an example of how we build relationships and maintain relationships with our community partners, is that we're there to help them and do whatever they need, whether it's part of a specific research project or not. Our relationships go beyond the bounds of any particular project. So the research, the COVID response that we're really talking about involves a number of different partners that we've worked with over the last 10 or so years, and those are 7 Generations Midwives, Toronto Aboriginal Social Services Council, Native Men's Residents, Inner City Health Associates, and the Native Women's Resource Centre of Toronto. So they've really driven all aspects of how we've developed this. And we also work closely with our elders that we have elders and 2 elders in residence at the Waakebiness Bryce Institute who work with us on a daily basis. And one of them is Clayton who did the opening here. The other is Wendy Phillips, who's Anishinaabe, who wasn't able to be here today with us. And we also have an elders council that meets 4 times a year that we bring our projects to and get their direct feedback and guidance on basically everything that we do, and we meet with them on the land. Meeting with our elders on the land is part of how we engage in ceremony as part of the research procedure. We also engage in other ceremonies as per what the elders on each team direct us to do. So Clayton, maybe you want to talk a little bit about that for a minute, about how we embed ceremony into our research design. Clay, are you still there? Can we allow Clay to speak?
Okay, I'm here. Can everybody hear me?
Yes, thank you.
Yes.
Okay, great. What that means is, you know, there's a colonized way of research, an indigenous research approach. I didn't quite understand what that meant at first, because I am not an academic. I don't claim to be one. I don't want to be one. All of this, and I get it. I understand, but my own research of understanding my culture, my spiritual practices, sitting with the elders was the most important thing, what I've done in my life. But they give me this title now. I did not give myself the title of elder. I just want to make that clear. There's elders and elderly, but we hold them with the highest respect. We all know this. They are the jewels. They are our precious ones. And so we've gone to them through the Haudenosaunee, to the Ojibwe, to all of the people of Toronto. Toronto is, paint this picture, Toronto is a very vast community of Indigenous people, and there's so many people, Indigenous people, who come here from all tribes, and they've come and shared their knowledge. And so we go to them, we ask them, we sit with them, and this takes time. And this is what I mean, it's ceremony. We offer our sema, we sit with their ceremonies, their sweat lodge ceremony. We sit in the circles, all of these certain ceremonies. And it takes time. So Western thought, they want it right now, they want that, or they want this, and it's about building our relationship. And I just want to say this about our elders. We hold them with the highest respect, because I want you to understand, I think we all understand, but the younger ones who are listening, some of them had to put down their bundles just to survive this thing called colonization. And I'm talking about my mother and my father's generation. My father has passed. Today is actually his birthday. And so thinking about him, and he was an activist, and he was a leader in Toronto. His name was Vern Harper, and I miss him. It's been a few years. So my thoughts are with him. But I think about that generation of elders who did all the work for us young ones, who suffered, did everything to do what we have today, all these so-called organizations. Because before, my mother reminds me of this. She's still here. And this is the 60s and 70s, late 60s, early 70s. There was nothing here in Toronto, Indigenous. So all the blood, the sweat, the tears, the activism, the struggles they had to do, it's just a handful of them. Everything they had to do to get us here, to have us having a conversation, right? And I acknowledge that, the hard work they did for the young ones, right? And I remind the youth of that, because now we're in this technological whatever, everything. And it's challenging for the youth. So I remind them of that. Maybe that's just my job. I don't know. But to remind the youth of that, right? And they went through a lot, right? Of racism, sexism, everything, right? The struggles they had to do to create everything. And it's so wonderful. And I think about just a handful that did that. And I also acknowledge the ones who couldn't do it, right? Who had to submit to this dominant way of thinking, right? Culture, everything, and had to, maybe they thought consciously, subconsciously, I will put this aside for the next generation. I will live for today. I have to submit to this so I can live, maybe the next generation will pick up the bundles, the medicine, that knowledge, right? That we have to offer ourselves and our communities in the world, Indigenous knowledge of how to approach research, right? So when they approached me, I said to them, I'm not too interested in this But I'm interested in this thing, having a conversation with our elders, talking to them and having through ceremony, because before we were healthy people, before the colonists got here, we knew who we are. Now we're in the process of healing ourselves. All of this, but we still, some of our elders still have that link to that spirit world, that spirit knowledge, and they still sit in ceremony from all over this place called Turtle Island. I've sat in the prairies, I've sat in, you know, in the Lakotas, everything. And I've, with my own eyes, I've seen them cure things that Western medicine says is uncurable, right? Through our ceremonies. There's the evidence, right? With my own eyes, I saw it, right? And the beauty of that. And so I get excited when I think about that, them coming to us, right? We're going to them, we're talking to them and say, help us, right? All of this. And we still have that, some of them have that connection to that spirit world. They can still talk with our ancestors and bring back that good medicine. So I get, that's why I came to the table, to help with that. So I hope that was, I know I can ramble on, but with that, I just want to say miigwech for that. And that's what we're doing. So miigwech.
Thank you, Clay. Yeah, absolutely. I mean, a lot of people talk about embedding culture and embedding spirit into research. And there have even been books about research as ceremony. And I think that there's, people say that, but I think there's a very limited actual understanding of what that means procedurally. And to summarize what Clay shared, is what that means procedurally is that all this stuff that you see on this slide, like the procedures, the Western procedures of the research, aren't really what the research is about from an Indigenous knowledges framework. Indigenous research based in Indigenous knowledges and not in Western Western research is about relationship, is about doing what the community needs, and is about being ongoing, and is about grounding everything that we do actually in spirit, which means that actually everything we do in the research is based in ceremony, meaning we get our name from a ceremony. We start all of our meetings in ceremony. We ask for divine intervention from Creator and our spirit helpers to guide the research in ceremonial processes throughout the project, not just, you know, an opening and a closing at the beginning and end of the project, or a naming ceremony at the beginning. It means having those elders there at every meeting, in every process that's embedding what we're doing with spirit and culture. So that's what drives the research more than other things, and ensuring that we're able to document and work on that in a way that preserves its sacredness, but also identifies that it's evidence-based from an Indigenous evidence perspective. Because not only do we need to do things in a good way, in a right way, spiritually, according to what the traditional people we're working with for, we as academic researchers in a university or working for the government, let's say, we also have to prove in a Western academic or policy context that what we're doing is evidence-based. And what we do is we want to demonstrate that the evidence is evidence-based from an Indigenous framework and not from a Western framework only. So that being said, you know, the communities come to me and say, you know, we're having this, we have to deal with this pandemic, this is what we need. So we provide the services for what they need, and then we sort of look at, okay, so how can we document this in a way that's going to be based on community voice and community need? Really, how can we evaluate this from an Indigenous perspective and not only a Western perspective? However, a Western perspective is important in some ways. We need to have meaningful epidemiological data that's both social and in hard numbers, so that we can have a tracking system and know who has what and where they are, so that we can put in those supports to prevent community spreading. We have steering committees, and I think Clay and I have talked about that, and we really ensure that our community councils and guides for the project are inclusive of everyone in our communities as much as possible, without overburdening people or having just the same people come all the time, because that's always an issue. I mean, you know, everyone who's on this call is probably active in Indigenous, on this meeting is active in Indigenous health, so you know that everybody comes to you asking you for things, and I don't think that's right either. So we have to make sure that we bring diverse people into our research teams, into our advisory councils, and into our work. And that's why we have what we call Indigenous youth research positions in the Institute. Those are any Indigenous young people who's worked in our communities from age, 16 to whatever, and I go way beyond what the actual Western definition of youth is, to hire people from the community to work on the research project and be paid and trained at the same level as graduate students, to build that capacity and to have those people embedded in what we do in Western academics. Some of the Western work that we're doing is, because I'm in public health, so they like what they call scoping reviews. Well, we're actually developing, and we're going to publish on this very soon, what I call an Indigenous scoping review. And really what that really is just like a deep literature review that uses 90% or more Indigenous academic sources and is heavily embedded with Indigenous consultation throughout the process. So, we're consulting with elders, we're interviewing community members, we're talking to everybody involved in the topic of that scoping review, rather than just basing it in Western academic information, which may or may not be biased against Indigenous knowledges and people. So in this particular project, we hope that there will be 500 participants from our community organizations. And we really want to talk to them in both surveys and in qualitative narrative interviews to understand what their experiences have been around COVID services, both within Indigenous organizations and outside in the Western healthcare system. We also want to talk to the Indigenous knowledge keepers who have or have not maybe been involved in the Indigenous COVID response, and to be able to talk to people in a group format after all this is finished, like in a year from now, to try to get people to share what was it that you experienced in the pandemic? What did we learn from it? How can we do things differently? How can we develop an Indigenous pandemic response so that we can be ready the next time an emergency happens, whether it's a virus or something else? How can we develop an Indigenous grounded response to a pandemic? And that's really what I'd say the greater goal of this is, responding to an emergency, but translating that to a greater goal that can help us get through other things. This part might be slightly more boring, but I'll just say quickly that we have Indigenous data analysis procedures that we've developed in other projects, and that we use and continually refine with the input of our partners and our traditional knowledge keepers. And we use everything that is part of the project to help us to get as much triangulation, as they say in Western qualitative research, or get as many sources as possible of information to put into looking at what we're going to do differently, or what we did well, or what we didn't do well in this COVID-19 response. We really hope that we can look at developing this at national and international levels going forward, and we'd love to partner with anybody who's on this call in terms of creating a Turtle Island or international Indigenous response to pandemics. So I'm happy to hear from anyone via phone or email if you want to have a meeting and talk about how we can work together in the future on this response, because the more we're together, the better we'll be. A very effective tool of the colonizer has been to divide and conquer, and it's opportunities like this event that all these wonderful people have put together that give us that chance to come together and rekindle our relationships and rekindle and create new acquaintances so that we can work together to address some of these things, because this is definitely not what the colonizing system wants. They want to keep us apart. They want to keep us fighting for research money. They want to keep us fighting for positions. They want to keep us fighting for resources. And we want to really go beyond that and work together with whatever we have. And we're happy to share whatever resources we have with any of you to do the work that you need to do. So, you know, of course, we want to share this information with everybody, and especially the communities that we're working with, because our goal, of course, is to make this relevant to the communities, and also to really, in my view, change policy, because the policy of how our system is doing things is not working for our people. And we have to give the policy people the right information from our communities to make those changes, because we can't change the system. Only the system holders of power can change the system. I think my experience is the best that I can do is try to give them the right information from our people to make those changes. So some examples of some of the initiatives that have come out of this research are a pandemic hotline. So one of our community partners, as part of this response, asked us to work with them to develop an Indigenous pandemic hotline. So we created the hotline, which is a referral hotline to provide direct access to internal agency and external community resources for Indigenous women in the city who need extra supports due to COVID-19. So our team worked very hard to create this hotline, and our team, along with 3 of the employees of Native Women's, staff this hotline Monday to Friday, including me. I have a shift on Friday, so if you call the hotline on Friday, I'm the one who's going to answer and try to get you the help that you need. Part of this also includes, this hotline, is that we've used our research money to pay for emergency housing for Indigenous women who are in crisis due to violence or other situations that have put them in a state of homelessness. Because the government was supposed to provide emergency housing to Indigenous organizations for their clients during the pandemic crisis, they ended up not doing that, even though the Prime Minister has come on TV and said they've given this money. The money just hasn't gotten to the community organizations. So as part of this project, we've provided hotel rooms for Native women who need a safe place to stay during the pandemic. And so we're embedding our evaluation into that. So that's sort of an example where the program drives the research. You know, it wasn't like we created a proposal that said, yeah, we're going to give temporary housing to Indigenous women in our project. We're going to create a pilot project and we're going to evaluate it. It was like the community said, we have women who have nowhere to stay, who are unsafe due to violence against Indigenous women and COVID-19, because the shelters are closed. So where these women would normally go is not available. So we created that service and that program, and then we're kind of developing the evaluation afterwards. So it's kind of a backwards process due to backwards according to the Western procedures of developing research, but it's forward according to community need and community driving. So that's been really exciting and excellent. A further thing that has happened with our community partners is our research team goes down to Native Women's Resource Center 3 days a week to pack hampers and deliver them out to Indigenous clients, women and their families across Toronto who are not having access to the food and the items that they need to live. So that's another part of the service of the research project that we've actively participated in, meeting community need and then meeting community through creating a program and then developing the evaluation afterwards. So I think that's it for me. I'm out of time. There's my contact information. You can email me or call me on my cell phone anytime. I may not be able to answer right away, but I will respond within a day. That's my policy, to respond to all calls and emails within 24 hours. So Merci Cho, thank you.
Hi, Dr. Stewart. Thank you so much. This is Maggie Grandin with AIHEC. We did have one question come through for you. I was wondering if you could say a little bit more about the Indigenous Scoping Review. Does that just include written literature, or does it also include interviews and such that you may have with elders and others?
Yeah, absolutely. It includes interviews that happen with community partners, with elders, and with youth and other people in the community who have offered to be a consultant for the project and to give us feedback. Does that answer the question?
Yes.
So yes, it includes consultations with the community members, but especially the traditional knowledge keepers.
Great, wonderful. Thank you so much.
Yes, Dr. Stewart, let me also, Carrie Billy here with AIHEC, thank you so much for your presentation, to you and Clay for your presentations. It's really fascinating and so great to find other people who share similar concerns and who are doing such amazing work. We're really excited. We at AIHEC developed some years ago the AIHEC Indigenous Evaluation Framework, which is a mostly used in social science education program evaluation. So we definitely would like to follow up with you. And I was taking some notes about some of the things you said, but I think one of the important things is, you know, when you were talking about embedding it, few people really know how to embed the research from your culture and your spirit, and the importance of relationship, community, and grounding things in ceremony, and the ongoing nature, that it's not just something you do for a few minutes at the beginning or the ending. It really is, it takes a lot of work. It's a long process. So involving people, we really just honor everything you're doing. It's really great, and we are anxious to hear the results, and we're so glad you're there doing what you're doing, such important work.
Thank you. That's so lovely, and I feel so humbled and honored to be here. It's a real privilege for me to be able to be doing this work in general. And you know, I do notice though, because I don't know, I know I actually only look like I'm 25, but I'm almost 50. So I just realized that, you know, over the last 22 years, and my kids are kind of grown up now, I just realized like why because I spent all my time working over the last 22 years, and now I'm kind of at that place where I'm like, why am I doing this? Nothing's changed. You know, I'm feeling frustrated with the system when I look at everything that's going on in the US and here with the racism and the colonialism. You know, the stuff that Clay's parents were like at the forefront of the AIM movement in Canada. They went to Ottawa, they did all the work. They created the change that we reap the benefits of now. But here we are, like 2020, nothing's changed. Everything's, we may have a voice, but nobody's listening to what we're saying still. It's the same stuff that we were all saying in the 90s, in the 80s, in the 70s. Like something has to happen, or else I don't know what, but we have to, the system itself has to change. Like we have to make them listen to what we're telling to do, because this just cannot go on. Cannot go on. That's my closing remark. So thank you.
Yeah, thank you. And I think, you know, what you were talking about, the importance of coming together with other Indigenous people. That's really how we can create that change, finish that work that Clay's elders and others started. And so it is important to reach out and work together with First Nations, with other Indigenous people around the world, because, you know, as Dr. Weahkee said, together we are stronger. And so we just appreciate everything we're learning from you. So thank you so much. Thank you again for being here.
Thank you.
And also, Dr. Stewart talked about involving students, youth, in all of their research. And so we're going to switch now to the kind of student-focused section, although of today's webinar, although I think all of this is really important. And hopefully we did have a number of students on, and I know the AIHEC tribal college students will be listening a little later during the summer. But our next speaker is going to talk about public health, kind of setting the stage for students who might be interested, and that's Dean Seneca. Dean Seneca is the CEO of Seneca Scientific Solutions, which is a public health and urban and regional planning corporation that provides tribal nations and others in assistance in economic and community development through strategic planning, epidemiology, and health research. Dean has more than 20 years experience with infectious diseases and infectious disease outbreaks. And he previously was the senior health scientist at the Centers for Disease Control's Center for State, Tribal, Local, and Territorial Support. And I've known Dean for at least 2 decades, maybe more. And he's always been really dedicated to working to improve the lives of American Indians and Alaska Natives. So Dean has also previously worked with the Seneca Nation of Indians in Western New York. And so thank you, Dean, for being here. It's great to see you and looking forward to your remarks.
Okay, great. Thanks for having me, Carrie. Yeah, we go back, right? I mean, it's been some time, but yeah, we're still here and we're still fighting that good fight. And, you know, unfortunately, some things have changed, but there's a lot that hasn't. So I'm just going to share my screen now. So I hope this works. Okay, does everybody have it there? Can everybody see it?
Yes.
Okay. So this is just, let me try to get my, so first I wanted to, okay, let's see if this works. No, it's not. All right. All right. So this is a little bit about, okay. All right. How do I move this? How do I advance this? Okay, let's see. Oh, all right. Okay, can everybody see that? I need to get a voice check or a sound check. Can everybody can hear me?
Yes. Yeah.
Okay.
Perfectly.
I'm trying to move this. All right, here we go. All right. So anyways, I wanted to say Weahkee to everyone that's on the line. It's really good to see all my old colleagues, and there's a bunch of people here now listening to this session. You know who you are. I miss you all. It's just good to see so many friendly people listening in on this conversation. I want to say Nyaweh to Rear Admiral Weahkee for those nice comments. I know that he has remembered me in the past, and we worked together actually on some student activities, 20 years ago, very early in our careers. And I want to say Nyaweh to AIHEC and ACES and Carrie Billy for having me be part of this presentation. My name is Dean Seneca. Like was said, my family is from Cattaraugus, the Cattaraugus territory, and my family is of the Beaver Clan. I'm actually an urban Indian. I grew up in the inner urban area of South Buffalo, and then my first job after undergraduate school was working for the Great Seneca Nation of Indians. So I'm here. I'm very, very excited. I hope we have a lot of students on the line. I love talking to students. And my subject is, what is public health? So we're just going to throw some things out there, and we're going to talk about what is public health, what is epidemiology. I'm going to talk about health disparities, and then I'm going to talk about some of the work I did regarding Ebola when I was involved with the Ebola response back in 2017. But anyways, let's get going. I have a lot of information, and I did hear that I have very little time. So, all right, how come this does not work? Okay. All right, here we go. So we've had some, we're right now in a very big public health threat regarding the COVID-19, but there's been many other, threats. We had hurricanes, we had the Zika virus, which I was actually a frontline responder to. We had Ebola in 2014, which is, I was literally in Sierra Leone chasing the virus in the jungles there. And we had Hurricane Sandy, we had the H1N1, we had Hurricane Katrina, and then the 9/11 attacks. And a lot of things that I've been saying in interviews that I've been saying, I said, I said that 9/11 really made us aware, but this COVID-19 is going to make us prepared. And that's something that we are seeing throughout the whole country. So we've had some achievements in public health. Vaccinations is probably the most significant, but most controversial at the same time, right? The other one that should be included on here that I did not include was taking the lead out of gas and gasoline, and we did that in the 70s, and you can totally tell the change in many of our motor stations now by taking that out. That has made a huge impact in public health. A lot of initiatives in tobacco, for example, and healthy mothers, and fluoridation in drinking water, and more control of infectious diseases, and safer and healthier foods. Public health is now on the map, and more people are engaging in public health. And with that, agencies like CDC are more common, and people in the public and throughout the United States are more aware of agencies like the CDC and NIH, et cetera. So what is public health? And, basically, for our students, it's the health of the public. It's the health of the whole. And actually, to follow up with the previous speaker, this is very traditional in many aspects. It's the health of everybody. It's the health of the whole group. CEA Winslow describes it as the science and art of preventing disease, prolonging life, and promoting health through organized efforts and informed choices of society, organizations, public and private communities. Public health is the science of protecting and improving the health of people, promoting healthy lifestyles, researching diseases, injury and prevention, detecting and responding to infectious diseases. It's, again, the health of the whole. And a lot of part of public health is looking at inequities. And we're going to talk a lot about those inequities. So what do we do as public health professionals? Many of us prevent. I mean, we all play a role some way in the bigger scheme of promoting health or doing something to protect people. We prevent epidemics, we address environmental hazards, we prevent injuries. But one of the things I like to promote for our students is we promote and encourage healthy behaviors, because this is where it all comes down to, is having healthy behaviors. And what we've seen related to COVID-19, when we lax from, say, social distancing and properly washing our hands and getting in crowds and not wearing our masks, what has happened 2 weeks after we've done those kinds of things? And those aren't the most positive behaviors when we're in the middle of a pandemic. We respond to natural disasters, and, we try to our best, provide accessibility to health services. So what is epidemiology? And basically I like to say it's the study and trace of diseases. It's really understanding the etiology of diseases and, finding the cause, of health outcomes, and different diseases in populations. You know, we study patterns and causes and the effects of diseases. We provide the scientific footing for evidence-based medicine. And we, you know, develop strategies for improvement in public health. And epidemiology is often referred to as the cornerstone of modern public health. And it relies on a variety of areas, including biology, biostatistics. I've had many of my biostatistics colleagues said, you know, epidemiology is really a component of biostats. And that would get a lot of huge debate. And the social sciences. So it's really, you know, the aspects of figuring out how to, you know, prevent diseases and how to protect public health. And one of my favorite things about what does an epidemiologist do, you know, we're called the disease detectives. And I love this analogy. You know, we're the disease detectives. We're trying to figure out everything you possibly can about a disease. You know, the cause, identify the people who are at risk, determine how to control or stop the spread or prevent it from ever happening. You know, this is critically important, and especially right now during a pandemic, everybody is looking up that term, epidemiologists. What do they do? You know, who is responsible? And what we're finding out a lot of right now, many of our tribal nations are looking to our tribal epidemiology centers to figure out, you know, what are they doing? What is their responsibilities, and how are they assisting? And I want to encourage our tribal nations to work with our epidemiology centers, because I do believe that a lot can be done when we all work together. And here are the 10 essential services of public health, you know, to monitor, to diagnose and investigate, to inform and empower, to mobilize, to develop policies, to enforce laws like no smoking in public places, to, you know, the link to provide care, you know, and we need to have a competent workforce. And if we ever get time, and we need to do more of this, evaluate. So this is kind of a very quickly, you know, what is public health? What is epidemiology? Now I want to get into health disparities. And in my opinion, American Indian, Alaska Native have by far the highest health disparities, more than any other population in the country or North America for that instance. And we're learning more that indigenous populations throughout the world have the highest health disparities, especially when we're finding out more information as we learn more about COVID-19. So, you know, we have, even with our casinos and even with all of these resources and things, we still have a major part of our community that's living below the poverty level. You know, people forget that casinos really just provide funding for a non-existent tax base, just so we could have basic amenities like everybody else in the country. And then if, you know, here are the top 10 leading causes of death. And I want to compare the American Indian, Alaska Native top 10 versus the United States. But let's look at 3, 4, and 5. Now, if we look at 3, 4, and 5, you will see that these are preventable. You know, we should not have these as number 3, 4, and 5 on our list of the top 10. And you could see number 5, chronic liver disease and cirrhosis. And, you know, I mean, it's no big secret that we do have a major drinking alcohol problem and issues in Indian country. And, you know, I don't want to say this from a preaching standpoint or that I am, you know, trying to sound like I am preaching prevention on this. You know, this has just really impacted all of our health. And I've had many of our Native elders say to me, if we could just get a handle on our alcohol issues, we'd probably have about 2/3 of our health problems in check. So, and then the other big thing is that, you know, Native people, a huge disparity is that we don't live as long as many other racial ethnic groups. You could see that for males and females, we die on average, much earlier in life than the African-American population, the non-Hispanic white population, and the Hispanic population. And this is right from Indian Health Service. If you look at it again, the chronic liver disease and cirrhosis, major contributions to this are, overly consumption of alcohol and binge drinking and those kinds of things. And diabetes is right up there, also very high. Unintentional injuries, assault and homicide, suicide, and lower respiratory diseases. I mean, these are that much more times higher than the average we're seeing among American Indian Alaska Native populations. Then here's a publication that I was co-author with. It was assessed a lot, and this basically discusses racial misclassification of American Indian Alaska Natives by the Indian Health Service contract delivery units, and it was a really popular article. And ironically and sarcastically, there is some validity to saying that people are born Indian and die white. And this racial misclassification is huge. If you look at other populations, let's say the African American and Hispanic populations, they are like +3 or 5% misclassification. When you look at American Indians, it was like ±30%. Which comes to the reality is that, we in Indian country have all different color, sizes, and shapes, and races, and different skin tones and everything. We are a very, very diverse group. And we need to get others to acknowledge our strength and our diversity. So in light of that, I wanted to talk a little bit about the previous slide. And I like the slide. I know it's a little bit older data, but if you look at this, our problem is that we die very quickly. So if you look at the black here, this is us, and we're dying very quickly, all the way up to age 64, 65. So this is a big issue for us. The thing is, if we live to age 65, we actually live longer than everybody else. The problem is that we're dying very, very young in these 3 areas right here. And again, this goes to a lot of issues, a lot of social determinant of health issues, access to healthcare, a lot of things that plague our communities today. And then unintentional injuries, if we look at unintentional injuries overall, again, you'll see that, American Indian, Alaska Natives are by far higher than all other races. And then, we have some serious suicide rates here. And this is a little bit older data, but it is very relevant today. And if you look at this line right here, this is the American Indians. You could see between the ages of 14 and all the way to 40, were by far higher than the other racial ethnic groups. And this slide right here, I usually, when I'm doing presentations for very large audiences like ourselves, and I'm in a group, sometimes I have to stop. I've teared on stage before looking at this slide, because looking at males 15 to 24 and their suicide death rates, I mean, by far more than everybody else. And why is this? Why are our males displaced? What is happening among our male groups that is causing this? And I think that our tribal nations really need to look more, and research really needs to look more into these issues. And then if you're looking at diabetes, again, you'll see that we're on top compared to all other racial ethnic groups. And everybody knows that diabetes has been a very big chronic disease problem and condition in many of our Native communities. And we have one tribe in the Southwest who has the highest diabetes rates in the whole world. Another, motor vehicle crashes. This is huge. I'm sorry, I didn't mean to. Motor vehicle accidents, you could see that, again, a lot of these accidents are related to the consumption of alcohol. You could see that, but you could see that compared to everybody else. These rates are very alarming. And then chronic liver disease. Again, I wanted to show how this is different from everybody else. Again, I'm not preaching. I'm not, the other thing is I would admit I've had my struggles with alcohol. I'm not saying I'm not better than anybody else in our communities and those kinds of things. I'm just saying that, we really need to look at this and we need to try to do our best to do prevention around this issue. And then we have tobacco. Tobacco is another very, very serious problem that we have. And I'm not talking about traditional tobacco, I'm talking about commercial tobacco in our communities. And if you look here at this slide, you could see the adults. And then if you look here, ages 12 to 17, I mean, these rates are still high, even compared to everybody else and the white population, but still much higher. So, these are some other things that, we have made, I believe, I want to say we've made major strides in the area of commercial tobacco, but we have much further to go. And then the one virus that we're not leading in as far as mortality, but we are on the rise. Here you'll see the African American community has by far higher HIV rates than the American Indians, but I recently published, published a paper 2 years ago where we saw that the incidence was on the rise in American Indian, Alaska Native communities regarding HIV. So here's a slide that I usually stop my whole presentation and say, listen, I want all the students, if anything you've heard from me, understand this one slide. And I understand now, or I've been seeing that many people aren't really presenting this slide anymore, or they're presenting a different version of the slide. I really would hope that IHS or NCAI or somebody else really, update or develop a new slide related to this. But I think I need to go through it because it's the most shocking and it's the most telling. And many of our Native physicians have presented this information, and I'm going to quote a few of them as we go along. And if we look at Indian Health Service per capita, and if we're looking at 2009 dollars here, and we're looking at, again, 1999 dollars related to medical for federal prisoners, right? So in this slide, the big thing that you need to understand is, per capita, here is all of the users of Indian Health Service. Here are all the users of the Veterans Administration and Medicaid enrollees and the FEHB medical benchmark. But here's the shocker. From $1999, which means this is a low number right here compared to IHS in 2009, literally 10 years later. People in federal prison have better health care per capita than many of our IHS service recipients. And this is very alarming. And I've had many of my colleagues, and I've heard them say, well, Native physicians say, well, I don't want to tell my patients to go to jail in order to get better health care. But per capita, numbers don't lie. And I guess for our students out there, I mean, we need to understand that this is a tragedy. This is a tragedy for Native people to have lower funding per person, per capita, than people who are in federal prison. So, okay, let's look at total of enrollment of minorities in schools of medicine. Here's allopathic medicine. And again, the CDC actually stopped making these charts. And we're trying to get the National Center for Health Statistics to start making these again. But if you notice, we showed you all of these disparities. We showed you all of this information. And now if you look at enrollment, where we are. This is our healthcare providers. This is why it's so important for you students to get involved and to pursue careers in health and public health and health research because of this factor right here. And then if we look at minorities in schools of public health, again, you'll kind of see the same trend. Here it is. So we have a lot of these problems, but we need you. We need you Native students, because you are our workforce to address these issues and problems. So a little bit about Ebola and my work in 2014 on the Ebola outbreak. You know, I was in Sierra Leone, where the first reported case was in May of 2014. I ended up spending the end of the year and in 2015 in Sierra Leone. And here is Sierra Leone in Africa right there. And, you know, a big thing related to Sierra Leone, Africa, was that they were really just getting over a civil war. And you could really see that in the population. There were a lot of sides, there were a lot of factions. There was a little hostility. And then all of a sudden Ebola hits, and then that makes everything much more, much worse. You know, people are living on $2 a day. So a very, very poor population there. And you'll see here by this chart, you could see the total amount of cases, and where I was in Sierra Leone, it had the highest amount of cases there. But also, if you look at deaths, right? I mean, if you look at deaths and you look at cases, we definitely have a large survival population here. So there are a lot of people who actually survived from Ebola. But I have to tell you, looking at the mass graves over there during the outbreak was just, it changed your whole life, literally. So, so then here's kind of a situational report, a map, you know, from the 23rd of May through 19th of April. And you can kind of see where a lot of the Ebola cases were. My district was right here in Bow. That's where I was sent. Here is Freetown. This is pretty much the city area here. Everybody came into here and then were deployed throughout the country. And then here are the deaths. You could see a lot of the deaths were pretty much around that urban area for this time frame. And one of the big things that I was able to do when I was in the response is I created a partnership with the United Kingdom, the USA, CDC, WHO, and eHealth, and the Ministry of Health. And basically what I was able to do is I wrote a proposal to the United Kingdom, and I was awarded $83,000 to train all the contact tracers and case investigators and supervisors in my district. And this was huge, you know, because we couldn't really tell who are the workers and who are the people, who was responsible for what. And so after, you know, and bringing $83,000 to a district in Sierra Leone was a huge deal for the community. Everybody was extremely happy. So one of the things that I did is I taught classes, and I taught, you know, 365 contact tracers. You know, I taught them, I basically taught the workforce, you know, what their duties and responsibilities were in the response, you know, what they had to do. And everybody, and the training was very successful. Everybody loved it, and everybody got involved, which was very, very, very exciting. You know, we were trying to just basically get a better handle of our workforce. So everybody, all the participants received a nice collared shirt, identification badges with photos on there, which were huge. Certificates, I ended up writing, or I had certificates printed up, and I had to sign every one of them, all 425 of them. But all contact tracers received a bicycle in the response. And, you know, a bicycle is really a big deal over in Africa. And you'll see as I go to show you some pictures. All right, so here, this is I'm teaching the class. Notice that we're not wearing masks. Notice that we're not really worried about the transmission of the Ebola virus through the air as much as we were through blood and droplets. But thinking retrospectively now, maybe we should have been wearing masks. Notice all the water is keeping everybody hydrated. That was a big thing in the response. And then the bicycles, everybody was happy related to the bicycles. I mean, that was like a huge deal for the whole community and the whole district. And here are some pictures of the community, you know, of again, a developing country, very third world. Here is our hospital. This is my hospital. This is where I worked out of. This is the water source. And here are the rooms and everything. And here are many of the patients walking around in the community. And here is just another people living here, another shack. And here's the roadway here. And then there were some farms in the back over here. You know, here are some of the farms here. And you can see in the back, there are some huts here. People do live in huts. You can see that. Here we go. Here's another picture of people living in the huts, and they have their farming area here in the front. These folks, I would have to stop, and they would, you know, check our whole car and, you know, make sure that we all had ID and we were all legit, because even between districts, people didn't want that Ebola virus. So, I mean, these stops were major. And everybody were armed with AK-47s, which made everything a little bit more interesting. And then here are folks that, you know, they're carrying their laundry. And then a lot of the Ebola signs here, many of them were just like this one. Here's the mountainside leaving Freetown. That's the urban area of Sierra Leone. And you can kind of see like where the living conditions are, and a handful of people and a handful of vehicles. And then here's a good example. So we have the water source. So people are drinking that water, bathing out of that water, washing, excuse me, sorry about that, washing their clothes out of that water. And then also, if you notice in the top area here, they're farming, all from the same water source. Now, this is not the best public health practice, but this is the reality of life over in Africa and Sierra Leone. And this is the Emergency Operations Center. You know, we were able to develop. Notice, you know, laptop computers only, all these boards and everything was done by hand, okay? Everything was done by hand. And here are the people that I was working with as part of my CDC team. This is Dr. Nadia Duff. This is Dr. Sarah Hersey. And this was our main epi person that was from Sierra Leone that we were training there. And I'm blanking on his name, and he would probably kill me for this. But this is our group that we were working with, and we would do reviews daily in each station in the Emergency Operations Center. And, you know, here's a lot of fine crafts, and these are just pictures on the skate going forth between my district and Freetown. And you can see this is I had to enlarge this in my camera, but this is the U.S. Embassy right here. And I was on the thruway, so this is actually much further than the picture, and actually you could see the American flag right there. And here is all of Freetown as we're coming into the city area. And this was my mode of transportation. When I left the response, I literally jumped on a helicopter, jumped on an airplane, and then I jumped into Atlanta, and it was like in warp speed. Everybody has different kinds of reentry. Reentry is a serious thing. It's a serious issue. You're just so worn out, especially when you develop and you get involved in these response, you get going in things, and by the time at the end of the response, you're only sleeping 4 hours a day and eating twice a day, and it just takes a lot out of you. And there I was, and here are some aerial photos from the helicopter actually going into Freetown. You can see a very big fishing population in this part of the area here. And, you know, you see a lot of these stop Ebola signs everywhere you go. And this is a public health aide that I was working with, and she was a volunteer from the Texas State Department of Health. We were leaving the response here, and we are just so happy that one, you know, we didn't get the virus, and two, that we were successful in our response. And I'm proud to say part of the team that actually put the curve into the ground. So, you know, moving from that into, all right, let's COVID-19, and I don't want to take away from the previous presenter, but, you know, the impacts are, you know, we have totally inappropriate funding for health. You know, one of the comments that I wanted to say in our disparities that Indian Health Service is funded at about $5 billion. We need about $20 billion in order to fund Indian Health Service, where natives have the same health care as everybody else in the country. That's my opinion, and I'm sticking to it. You know, we do have a sparse health workforce, and that's a challenge. But that should not deter us from doing this work. I firmly believe, and I've said, if you have passion for your community and you want to learn, we can teach you how to respond to this COVID-19 and play a significant role in the response. You know, we do have these huge health disparities, you know, and with those health disparities give us these pre-existing conditions, you know, which really makes this, you know, which what has been said by many, including NCAI and Indian Country, this could be the perfect storm. And, you know, it's really sad to see our brothers and sisters, our Dene brothers and sisters, you know, really just struggling and fighting this. And I think we're just starting to win over there with Navajo Nation. The case counts have gone down. The last two sit reps I've read, and I hope we're able to keep that going. Social determinants of health. This is big for our students, and I really want people that the social determinants are the conditions in which you are born, live, learn, work, play, grow, worship. These are the circumstances in which really shape your health. And it's really good to understand the social determinants of health as you get into the health career field. The other big one, and I think this is totally appropriate for what's going on now, is, you know, race matters. And we've been saying this for a long time, and we've addressed a lot of this racism, and we probably will continue to do so into the future. But racism and health is a serious issue. And my colleague, Dr. Kamara Jones, has really been a champion of this, and she's at Morehouse College addressing many of the issues of racism and health. And I'm actually glad to say that I was co-chair with her on the Racism Health Work Group at CDC. And all of this comes to a head, and we all find out that a lot of the things that we're you know, fighting with today, the issues of alcoholism, you know, the issues of, you know, depression and suicide, and you know, all of these other behavioral health things that we're experiencing that really impact our health, in my opinion, are related to the historical trauma, intergenerational trauma. You know, American Indians have experienced a ton of trauma in the last 2 centuries, 3 centuries. And, you know, these things, you know, come out, and we as people and populations react out. And that's why we have a lot of these high rates of suicide and homicide and child abuse and alcoholism. I'm a firm believer it's related to the concepts of intergenerational trauma. And there's something called epigenetics. And if you really get involved with epigenetics, you'll understand, and it's really the study of populations previous to your own and why health conditions were experienced then, and what are the things that we are, and how that has caused the things we are experiencing now. But we can't lose sight, you know, for our Native students out there, that our health is holistic. You know, it really is the balance between the physical, mental, spiritual, and emotional well-being. And we need to keep holding on to that concept and understand that that's the core of everything that we learn and everything we do. And lastly, one of the last things I want to leave for our students is, I want to leave this with you. You know, have a good mind. Now, what does that mean? Having a good mind is, you know, a very big Haudenosaunee teaching, you know, and the concepts teach us to be aware of our thoughts and their intent. You know, have a good mind, have empathy, have love, have security, care for people, be more kind, be the bigger person. You know, we have a lot of cynicism in our community, and honestly, to me, that just kills us. You know, when you have jealousy and you have cynicism, and you have things like that. You know, have a good mind. You know, believe in, and when you have a good mind, that will result in your actions and your behaviors, and you'll have good intent. And then through that, you're connected to yourself spiritually. You know, when we become aware of our thoughts, especially those that have a kind and loving intent, we naturally allow ourselves to become spiritually in tune with the Creator's wishes. There's nothing more that can be said, and that's what I want to leave with our students, is to have a good mind, practice these things and these culturally appropriate teachings, especially right now when we're in such civil unrest as we are as a nation, as North America. And then the other thing is, I need to put in a plug for the American Indian Science and Engineering Society, ACES. I want our students really get involved with ACES. ACES is a great organization, as well as AIHEC. You know, if we're able to do ACES and we're able to get a fellowship with one of these agencies like CDC or NIH or one of the federal entities, you know, we create ambassadors to our tribal nations. And I think that that's always a positive thing when we're trying to promote education and health. And I've had the opportunity to speak at many Native heritage celebrations, and I always leave my presentations with this thought, especially having really have fought racial discrimination strongly. I like to leave on this note.
Thank you, Dean.
In light of that, are there any questions?
Dean, thank you so much. This is Maggie Grandin again with AIHEC. I do have a couple questions for you. Real quick, the first one is, did the type of training that you provided take place in other districts beyond Bow?
A version of it did. Not like, well, actually, you know, what the funding was really is to train everybody there, and the training materials that we developed for our training, we were able to share with the rest of the country and the rest of the response, actually. So I know that other districts were doing some version of that training, but not everyone got a bike or a certificate or a t-shirt or an ID badge. That was really specific to my district. But the training materials went much further throughout the response.
Thank you. Another question, this came from someone specific and relates to their experiences a little bit, but how do we best help our students as they move to learning at home for reasons of health safety? I have watched Native people learn about health safety, like workplace hazards. Is it the same now for school place hazards?
Well, you know, I think it's important to surround yourself with as many positive, you know, reinforcing people as possible, right? And so I think if we're able to, you know, learn in those environments at home, take the extra steps to go above and beyond, to do a little bit more research, to do a little bit more writing, you know, I think that we're able to, you know, still get the same level of education as if you were in the school setting. You might not have the same diversity of input and response that you would get in a classroom setting, but I think you'd still be able to learn the materials the same way. I hope I was able to answer your question.
Thank you. Another question, are there measures or trends that reflect the impact of COVID-19 on addicts, such as meth users?
You know, I'm in partnership right now with Roswell Cancer Institute, and we're writing a paper on COVID-19 in Indian country, and we have a draft developed. And one of the big things that I actually brought to the attention of others was the drug community, all right? The partiers and things, and you know, how do we address that? And, you know, I haven't seen, not meaning that it does not exist, but I have not seen any data that addresses just COVID-19 with those addiction populations.
Thank you again. We just have a couple more questions.
Sure.
Given the dismal health statistics, why do you think so few American Indian and Alaska Natives go into health careers? What can we do to get more young Natives interested in health careers?
I don't think the health statistics have anything to do about Natives getting into health careers. What I do think is I think it's getting Natives excited about education. And I think what we need to do is start much earlier. You know, the average people in their teens, you know, really get excited about, you know, careers and things. I think we need to start as early as, you know, 4th, 5th grade, you know, getting our students attuned into getting excited about education. Because I think that that's the key. You know, we have so many of our communities, you know, by the time that they're teenagers, just totally disassociated with education because their parents weren't excited about it. The school isn't really engaging with those students. You know, there isn't a lot of social support at home. And quite honestly, very young, many of our Natives, you know, at very young ages, and including myself, I mean, my mother had me at 16. My father was 18, very young. You know, we have people right at that age having babies. So, you know, that also takes a major, you know, starting a family, that also takes a major curve in versus, you know, getting involved right in education immediately. So there's a lot of factors involved with that. But in order to address that, I say, is grabbing our students much younger and much earlier and getting them excited and involved and just pumped about education, regardless of what it is. You know, we can guide toward health and attorneys and engineering and you know, different professions in the labor force. But my thing is just getting them excited about learning. I think that's the key right there at a much earlier age.
Thank you. And Dr. Stewart, I don't want to put you on the spot, but did you have any additional thoughts that you wanted to add before we move on to our next question?
Well, just that, you know, about the education of our people in healthcare, it's really about not so much, you know, just accommodating their needs, but really shifting the paradigm of health and education and having that reflected in our training programs for Indigenous health per se, and then just for health education in general. You know, there is a national and international discussion right now on shifting the paradigm. How that's going to actually shift in real life, I'm not sure, but I think we need to stay active in that discussion and ensure that the systems remain accountable to making those changes to diversity and a commitment to ending systemic racism in healthcare education specifically. I think that's when our people will start going to school to become doctors and nurses and social workers and public health providers, because the system is really laden with colonial assumptions, and the public health, for instance, full of the social determinants of health, which actually only exist to make Indigenous people marginalized and ill. We need to popularize Indigenous determinants of health, which are completely different to what the Western system says we need to be and have in order to be healthy.
Thank you. I just have one more question here, and then we didn't quite get through everything, but I would encourage you to definitely email Dr. Stewart or Dean Seneca directly if you do have any additional questions. But I did want to just pull out one more here real quick. Do you know of any Indigenous evaluation methodologies that have been implemented in Turtle Island?
I think I would have to defer to some of my other colleagues on the line on that one. I know that we have adapted many, or we have indigenized many evaluation methods that currently exist. I know that we've done a lot of that throughout the country. But I don't know of an indigenized evaluation method right from the ground up. Does Dr. Stewart know of one? But I do know, you know, with my work with the tribal epicenters, that we had many, evaluation was a key component to many of the grants and things that we were receiving. And we would take the existing evaluation methods and and reform that and make it more applicable to our communities.
Yeah, I would agree with Dean that there's been a lot of adaptation and accommodation of Western evaluation methods. There has yet to be actual Indigenous evaluation frameworks published. We're working on publishing a toolkit for that right now based on some of our Indigenous community research. So I think that's something that we all need to work collectively on, is creating some of these things to share with people. Because the short answer I would say is no, there isn't an Indigenous evaluation framework that's out there, but there's a lot of great adaptations that have been done for sure.
This is Carrie, Billy. Thank you both for your great presentations. It's just been so fascinating listening to you. AIHEC does have an Indigenous evaluation framework that we developed. It was led by Joan LaFrance and Richard Nichols several years ago. And Joan's actually in the process of revising it. We published it first in 2019 or 2009, and have been testing it with tribal colleges, and now it's being, as I said, Joan's just completing the update, so we actually will have the new version published sometime, hopefully this year or early next year. But as Dr. Stewart was saying, it is a very labor-intensive, a time commitment, involving elders and the community throughout the entire process, even before you begin. So we think that's one reason people have kind of difficulty sometimes committing to it, but it really is important to staying accountable to your community. And we've never used it in a health context. We've only used it in an education context. So I'm sure that would require some adaptation also, but it is on the AIHEC website, AIHEC.org, and then you scroll down to portals and Indigenous Evaluation Framework. And I see someone else said Dr. Herbert Benally on Navajo has developed an Indigenous evaluation process. And I think in the United States, the NICWA, that are the Native American, the Child Welfare Association, has also developed a really good tool used in their context, in a community context. So again, thank you all for being here. Dean, if you could stop sharing your screen, I'll put up the evaluation. But again, okay, let's see, let me get the right one. Okay, I'm gonna do this one. Okay, can you see that? Oops, sorry, I went the wrong way.
Nope, we don't see it.
Okay. Total bummer because I can see it. Let me see. So I think the only thing that we have left is let's see, let me try this one. Can you see that one?
Yes.
Yes.
Okay. Current slide. Yeah. So again, thank everyone for being on the call today. We really appreciate it. Trying to get the right slide. Oops. Oh, there. Oh, there's the evaluation. I didn't see it. I have all your pictures over there. But we do have a post-program evaluation, which you can get through the www.nnhrti.org website or the longer URL that's up there. But NNHRT is the National Native Health Research Training Initiative, and the evaluation is right there. So if you could just take a few minutes and click on that and do the evaluation, we would really appreciate it. We are having, as we said earlier, this is a monthly webinar series, the first of 6 that we have scheduled so far. So they will all be the 3rd Wednesday of each month at 2 p.m. on different topics related to Native health, and particularly in this environment of the COVID environment that we're in now. And I just want to close again, so we hope you'll join us for that. And I want to close again by thanking Dean Seneca and Suzanne Stewart and Clayton Small for being with us today and for teaching us. I feel like I have learned so much, and we're excited to share this, continue sharing it with the tribal college students and people throughout Indian country. Your words have been so important, so impactful, and great lessons and stories for us to think about and to share. So thank you all so much for being with us today.
Yeah, thank you for having me. I deeply appreciate it. And it was great to touch base, and I know that many of our colleagues are out there supporting us. And thanks to you, to AIHEC and Carrie, for the great work that you're doing and keeping the fight going. Yahweh.
Yep, thank you. Thank you, everyone. And we hope to see you again next month.